morning, everyone. Today, the topic of presentation is role of prosthetic rehabilitation. Myself, Dr. Rekha Joshi from Dental Department. So, we will be looking forward what a maxillofacial prosthodontics can be important, how it can be important for the treatment of head and neck cancer treatment. As we can see, India has the second highest number of oral cancer cases. So, oral cancer treatment can be devastating effect to the patients due to disease itself and the aggressive nature of the treatment. Functions such as speech, swallowing, mastication can be significantly affected. So, maxillofacial prosthetic rehabilitation aims to restore the oral function, cosmetic, following the surgery and treatment towards a treatment baselines. So, as a dentist, the practitioner in the field of a cancer has become increasingly complex and challenging. The role of a dental practitioner has become increasingly complex and challenging. Hence, it is very important as a dental practitioner in head and neck cancer to assess the need for oral rehabilitation before starting with the cancer treatment therapies. As you can see, it plays a very important role in every aspect of the surgery, radiotherapy, chemotherapy. During surgery, at the stage of planning, during the surgery, post-surgery, even in case of radiotherapy and chemotherapy, it plays a very vital role prior to starting of radiotherapy, chemotherapy, as well as ongoing and post-radiotherapy and RT treatment, chemotherapy treatments. So today, it is very important to do a prehabilitation of the patient. What is prehabilitation? It is basically intervention between the cancer diagnosis and treatment initiation. The importance of rehabilitation is only to do the strategies so that rehabilitation is done prior to the surgery and minimum amount of interventions are required post-surgical and post-cancer therapy treatments. As you can see, pre-treatment oral rehabilitation assessment as a dentist, the thorough clinical examination and radiographic and OPG surveys are done. The clinical examination done keeping in mind the prosthesis or rehabilitation point of view. For that, pre-op study models are also recorded, and any teeth which is required for extraction, it is noted, conveyed to the surgeon. So during the time of surgery, all the bad teeth are extracted. Surgical obturators, if indicated, are placed. Also, in case of benign tumors, insertion of primary osseointegrated implants are done during the time of primary surgery itself. So all the pre-prosthetic procedures, placement of obturator, placement of implants are done during the time of surgery. Also, you can see the dentist plays a very important role, as I said, to prevent any kind of post radiotherapy, chemotherapy complications. For that, extractions if required are done prior, and any conservative treatment, if indicated, is done prior to the treatment. Post-cancer treatment interventions, that is surgery, radiotherapy, and chemotherapy, as such, no active treatment is indicated. Maintenance is the goal. So simple restorations, partial complete dentures if indicated, and complex rehabilitation involving osseointegrated implants and interim maxillary obturator are planned. So this is the way how we plan the rehabilitation of the patient, of head and neck cancer patients. So basically, it is a team approach where the primary caregivers are the surgeons, radiotherapists, and the chemotherapies. But without the team of a multidisciplinary rehabilitative team like nutritionists, physiotherapists, dental specialists, speech therapists, physicians, psychologists, and nurses, the treatment provider becomes little difficult. So, coming to the prosthetic management of the defects, generally we encounter most often like in the mid-facial maxillectomy defects and the mandibular defects. So how we restore the maxillectomy defects? Maxillectomy defects are mainly restored either with prosthetic rehabilitation or with surgical reconstruction. In case of prosthetic rehabilitation, we give surgical obturators, interim obturator, definitive obturator, which can be implant supported like endosseous implant or zygoma implants. Also surgical reconstruction where soft pre-flap and osteocutaneous pre-flap are being placed. Coming to the mandibular defect, they can be either restored with soft tissue graft or osteocutaneous microvascular free flap reconstruction. So when the mandibulotomy defect is restored with soft tissue graft, as a prosthodontist, we provide a guide by prosthesis for the bringing the teeth into occlusion. When the mandibulotomy defects are restored with a microvascular osteocutaneous graft, it is very important to consider condyle as a important aspect, preserving the condyle. If the condyle is not preserved, the fibula acts as a cantilever, and if it is restored with prosthetically, it won't be used for mastication. So placement of the implants is considered whenever a surgical reconstruction is done. It can be a primary placement of the implant or a secondary placement of the implant. The primary and secondary placement of the implant is derived by multiple factors. We will be seeing one by one. So the factors to be considered for the implant placement are the site of the implant, it is mandible maxilla, it is contralateral site of the cancer treatment or same. The site where we are placing, whether the site is radiated, non-radiated, what kind of radiation is being given, whether it is an IMRT or conventional RT. The dose plays a very important role for the survival and prognosis of a prosthetic rehabilitation. Also, whether the implant is placed in a grafted bone or in a native jaw. Also, the tumor prognosis depends on what kind of tumor has been resected, whether it's a benign or it's a high-risk recurrence tumor. Age plays a very important role. In case if a patient is with a 70-year or 70 plus with a medical complication is coming to the for the cancer treatment therapy, we looking into the dexterity of the patient. Implants may not be indicated in such cases. Also, the oral hygiene maintenance is a very important point to be considered. If the patient's oral hygiene maintenance is not proper, implant may not be considered in such cases. So, coming to the timing of the placement of the implant, there is always a question whether to place a primary placement, consider a primary placement or a secondary placement. What is primary placement? Primary placement is a placement where implant is placed right away after the removal of the cancerous lesion, and oral rehabilitation is planned after complete cancer treatment, that is surgical implant placement, post-operative chemotherapy and radiotherapy. Secondary placement is when initially the cancer treatment is totally completed. After that, after the completion, after 6 months to 10 years, maybe 6 months to 1 year is the time period, the implant placement and oral rehabilitation can be considered. So the 5-year survival rate of the primary placement is 92.8%, whereas the 5-year survival rate for the secondary placement is 86.4%. Early prosthetic rehabilitation, advantage of the primary placement is early prosthetic rehabilitation is possible. Extra cost and additional surgical implant placement procedure is prevented, and it is always a treatment of choice in the benign tumors. So primary placement of the implant in the anterior jaw should always be considered, though the tumor is squamous cell carcinoma. The disadvantage of the secondary placement is implant placement waiting period is from 6 months to 1 year. Delayed prosthetic rehabilitation. Irradiated fibula might be considered contraindication of the implant, though we have placed the fibula, but after radiotherapy, it might be considered, it might not be an ideal condition to place the implants. Also, it adds on to an additional post-procedure cost and to the surgeon. So now coming to the defects. First we'll be covering will be maxillectomy defect management. So whenever there is a maxillectomy defect, there is a hypernasal speech, leakage of the food bolus and liquids, impaired mastication, and various degree of cosmetic deformity. So the goal of a rehabilitation, whether it's a prosthetic or a surgical, is to restore the partition between the nasal and oral cavity, restore palatal contour and maintain the tongue space, replace missing dentition and restore midfacial contours, provide retention, stability, and support for prosthesis. Now, as an obturator, it is a shorter operative time, shorter post-operative hospital stay, and better visualization of the maxillectomy cavity for the surveillance. And it is the most common approach in treating the maxillectomy defects. Now, coming to the reconstruction of such defects with the local or regional flaps, the advantage is it allows for the dental restorations, freedom to orient and shape and insert the flap as needed, massive midfacial skull base lesion, immediate reconstruction reconstruction is mandatory, and some defects amenable to rehabilitation with prosthesis after free tissue transfer reconstruction is performed. The main disadvantage is longer surgical and recovery time, increased potential for complications compared with prosthetic operation, and free flap may delay the diagnosis of local recurrence. This is very important point to be considered in case of high risk cancers. So what are the alterations that we will be requiring to enhance the prosthetic prognosis? We will be seeing one by one. The first is the skin grafting. It is very important to line the cavity with the skin graft, partial thickness skin graft. The advantage of this is that it creates a divergent lateral wall, which when engaged, as you can, it creates a divergent lateral wall, which when engaged, provides a good retention to the defect site. Skin line cheek lumps are more flexible than the one with epithelialized spontaneously. Also, the skin line defect provide keratinized surfaces in the defect that can be engaged more aggressively with the processes, thereby improving stability, retention, and support for the obturator processes. As you can see, this is an edentulous maxilla. The defect which are lined by the skin line can be the engaging of these defects enhance the stability, retention, and support, whereas the defects which are not lined can lead to traumatize the tissues, and bleeding from the defect area will be more frequent. Whenever there is a case of a total palatectomy, it is important to line the defect with the skin graft so that laterally we can engage the obturator and provide a good retention. This can help in swallowing to the patient, but mastication will be severely compromised. So when the defects, like maxillectomy defects, are placed anteriorly, the importance of skin lining of these defects is that it has got improved support. Lip contraction of the lip during the as the healing happens is less, and more control over the lip contours with the obturator prosthesis. Also, as compared to the defects which are not lined by the skin graft, these wound was closed primarily and the raw tissue surfaces were not skin grafted. The result, the upper lip contracture and normal lip contours could not be restored with the labial flange of the prosthesis. So if it is not lined, even prosthesis cannot help to regain the earlier cosmesis. Now, access to the defect should always be maintained. If the turbantines are retained, with time, there are chances that it will grow. So it will occupy the space of the oral cavity and violating the obturator prosthesis and tongue space. So ideally, they should be removed during the time of surgery. Also, whenever a defect is lined with a soft tissue flap, you can see the distortion of the palatal contours and elimination of the tongue space. These patients could not be fitted with a prosthesis. They are unable to masticate, and their speech articulation was severely compromised. Though a free flap was used to close the cavity, but the bulk of the tissue was so much that even prosthesis cannot help to regain the speech and swallowing for the patient, because the prosthesis will be, every time it will be dangling over the soft tissue. Now, retention of the premaxilla. In the edentulous cases, it is important to retain the premaxilla. At these, the bone in this area is very dense, and the length of the bone to place our implants is good. So it is important whenever possible to retain the premaxilla. Also, in case of dentate patients, retaining premaxilla help us to provide more anterolateral spread. So, a trichoid contact is gained for the our retentive components. Retention of the key abutment tooth, the last tooth from or adjacent tooth to the defect area, is very important, as it is the one who bear the greatest stress, and bony cuts through the alveolus next to these tooth should be interproximal rather than interseptal. In the patient, the transalveolar bone cut was properly made, as you can see in the picture which is on the left side. The result, this abutment tooth is circumference by the alveolar bone, making it suitable for partial denture abutment. Whereas the picture on your left side, the three pictures, the bony cuts were made interseptal, exposing the root of the teeth, so compromising the life of the teeth, and hence it cannot be used as an abutment for the obturator prosthesis. Also, the palatal mucosa, the tissue should be covered by the palatal mucosa whenever possible. So whenever a soft palate defect is seen, it becomes very difficult to seal such defects due to remnant movement of the remnant soft palate. Speech is most commonly affected function and nasal intonation is common. Impression is needed to mold functionally and to achieve effective seal. This is how we provide a velopharyngeal obturator to the cases of soft palate defects. So now coming to the types of the maxillectomy obturators that we provide. So this is a case of an immediate surgical obturator wherein towards our left side we can see a slide, we can see the lesion, pre-op impressions are made, mold is fabricated and the markings are done, the cut sections of the surgery, how it will be performed. Accordingly, a mock surgery is performed on the model and an obturator is fabricated. So the moment the tumor is or the cancer is removed, we place our surgical obturator in place. The advantage of this is at the day 3 or day 2, the patient can start swallowing, he can take sip of water, soups, and importance of this is at the time of discharge, patient can go without rice too. And it increases the confidence of the patient. So there are two types of surgical obturator. The first one which we saw was an immediate surgical obturator which is given immediately after removal of the cancer. And this is a delayed surgical obturator wherein the procedure is same. Pre-op impressions are made, model is fabricated, mock surgery is done, but the obturator is placed on the day 5th post-op when the surgical pack is removed. Coming to the interim obturator, this is a case wherein the flap was given away and there was a connection between the maxillary sinus and the oral cavity. So this is how we are trying to engage the undercut and with the help of adhesives, the obturator was in place. Coming to a case of a complete denture with obturator, as you can see the defect, the premax, it's a completely edentulous maxilla with the right side maxillectomy done and the premaxilla is preserved. We saw the importance of preserving the premaxilla, the impressions were recorded and this is how the obturator was fabricated and this is the final processes in C2. Again, a case of an interim obturator wherein implants were placed. These are the zygoma implants which were placed through the cavity and the implants cannot be loaded immediately. So to cover the defect, an interim obturator impressions were recorded. Interim obturator was fabricated and placed in C2. So interim obturator is the one which is given after, which is considered after 15 days post-op, and it can go till 6 months or 6 months if the patient is not radiated, or if the patient is radiated, interim obturator works till 10 to 12 months. So once if the patient is radiated, 10 to 12 months. So after the interim obturator, next comes is definitive obturator. We consider a patient for a definitive obturator whenever the tissues are completely healed, they are healthy, and all the radiation side effects have been minimized. So this is a case, as you can see, it is an anterior maxillectomy connecting the nasal cavity with the oral cavity. The defect is nicely lined with the skin graft. The impressions were made, and then definitive cast partial obturator was made, and this is how the happy patient. So this was about the defects which were not reconstructed with free flap and osteocutaneous fibula graft. So coming to the defects, maxillectomy defects which are placed with the osteocutaneous, reconstructed with the osteocutaneous fibula flaps. So here we have placed the implants. Secondary placement was considered in this case because of the radiation. We have to wait for at least 1 year post radiotherapy to consider the placement of the implants, and this is how the processes was given in place. Now coming to the hemimaxillectomy cases which were restored with vascular graft with implants, case done by Dr. Dilip Deshpande sir. So this is a clinical photograph of a fibula which was placed in the maxillary region, and again the secondary placement was considered in this case. 4 implants were placed. You can see the position of the implants in the right side of the see the position position of the implants in the right side, they were clearly coming into proper occlusion, and we can already predict the outcome, how it can be aesthetic outcome with proper placement of the implants, and it's an OPG, how it is nicely osseointegrated into the fibula. So a close impression was taken, and this is how the hybrid prosthesis, which is screw retained, was placed. Now coming to the defects of glossectomy defects, rehabilitation of glossectomy defects. So what we do if there is a total glossectomy?
It's in that zoom mode, that's why.
That's what it is. Okay, so we'll be seeing in another slide the prosthesis. So this is a total glossectomy case where a total tongue prosthesis was given. So there might be a combination of a tongue prosthesis along with palatal augmentation prosthesis. For partial prostatectomy cases, we only consider palatal augmentation, as you can see in the third picture. We'll be seeing the case one by one. So the rationale for this is like articulation is affected because of inability of the patient to attain proper cavity shape and constriction necessary for precise sound production. Resonance is affected because of the change in the volume of oral cavity after glossectomy. Mastication and deglutition are severely affected. So reduction in the size of the oral cavity, thereby the goal is to reduce the size of the oral cavity, thereby improving the resonance characteristic, direct the food into the esophagus, protect the underlying fragile tissues, and development of the surface of the residual tongue tissues to contact during speech and swallowing is the only goal to rehabilitate such cases. So what are the indications? There should be an adequate mouth opening. At least 1 year should have been lapsed after radiotherapy. Mobility of the residual portion of the tongue should be considered, and remaining healthy dentition should be considered. Manual dexterity of the patient is also important. So since he has to always remove and place the actual tongue prosthesis, and realistic patient expectations. So this is a tongue prosthesis wherein total glossectomy was done, impressions were made. You can see the trial was done, and this is how the total glossectomy tongue prosthesis looks like. The tongue is fabricated in such a way so that it helps in deglutition, it helps in swallowing basically rather than mastication. It creates a pathway posteriorly so that patient can direct the food or the bolus directly into the esophagus. This is a palatal augmentation prosthesis. It's basically speech aid prosthesis. Whenever there is a partial glossectomy or a total glossectomy and the palate is deep, we have to consider both palatal augmentation as well as tongue prosthesis, so that whenever a patient is trying to speak, the tongue prosthesis contact we lower the palate. So tongue prosthesis contact the palate and patient is able to articulate the speech. So coming to the extraoral defect, now you can see this is a very extensive, huge defect. The patient has been operated third time. So you can see third time the patient was operated, and during this time whatever flap the plastic surgeon was trying, it was just giving away, it was just not staying back, and the patient was completely the physically, emotionally and psychologically the patient had given up. So and the disadvantages were, or the side effects of this kind of defect was, there was continuous dryness, soft tissue irritation, mucositis, continuous cupping, and patient cannot go out, and he also stopped allowing the visitors to come and see him. So the only option left with us was to plan or give some coverage to the patient. So what we did, we took an impression, waxed pattern was made, it was tried, a trial was done, and mold was fabricated. Color matching was done. We take shades from different areas because there was not a single tone, like patient was, there were multiple shades. So we took the trial and silicone was packed. It was retrieved before polishing. It was tried on the patient. As you can see, we have just tried to cover the defects so that at least patient can go out and uh, have some social life. Coming to another case of a combined maxillectomy with orbital prosthesis. So this is a lady who got mucormycosis, and during that process there was a total maxillectomy which was done, and complete orbital left orbital excenteration along with the soft tissue was performed. You can see the defect and the deformity of the midface and the left side area. This was the intraoral picture of the total maxillectomy which was done. We fabricated an obturator prosthesis and dentition was given. So in case of this total maxillectomy defects, obturator will help just in swallowing because there is no support, there is no bony bed behind. It will only help in swallowing, and the teeth were given to enhance the aesthetics and lip and support the upper lip.
Was it retained?
Sir, by engaging the lateral undercuts, sir, lateral and anterior undercuts. So these are the. So you can see these are the posteriorly I have extended here. Anteriorly in the nasal aperture I try to extend here, and with the help of the adhesives we have tried to retain the prosthesis. So, sir, as I said, it will be only helping in swallowing, sir. Mastication won't be able to masticate because the moment patient is biting, it is again going upward because there is no vertical stop for it.
Even when you don't have other teeth, you can still retain it with adhesives.
Sir, with the adhesives and by engaging the lateral undercuts. So it is important if the cavity is lined with the partial thickness skin graft. So we can aggressively engage the lateral undercuts. And in case of, especially in case of total maxillectomy, because not every patient can afford zygoma implants or other advanced prosthetic
These
rehabilitation.
cases generally are reconstructed with fibular graft.
Ideally, fibula
This
graft.
comes quite well.
Right. Yes.
So can you use retention implants?
Zygoma implants from that. And children have any zygoma left on the left side, right side, we can say it will be only unilateral. So that prosthesis still will not have that the kind of stability which we expect to have. Unless there's no other choice.
So for the extraoral defect, trial was done, and this is how it came out to be. Little extrinsic coloration was pending, and this is how the look after placing the obturator and the orbital prosthesis. So coming to the nasal implant supported silicone nose prosthesis. As we can see, this is a case of actually xeroderma pigmentosa. The patient getting exposed to sun and UV, it causes damage to the skin, and there are small ulceration every now and then, depending how the patient, how frequently is getting exposed to the sun. And most commonly it affects the nose area morely because it is in the direct contact. So you can see it was implants were planning was done and implants were placed on the nasal floor. 3 implants were placed. After the sufficient healing and osseointegration of the implants, maybe around 2.5 to 3 months post placement of the implants, it was considered for the prosthetic rehabilitation. So the impressions were made. Impressions were made, and this is how the impression looked like. After making the impression, a bar and clip attachment framework was attached to the existing implants, and over this a silicone prosthesis was fabricated. You can see here in the lower picture We have done some pigmentation on this to match the skin as if the patient was a xeroderma pigmentosa. You can see the outcomes. So it looked like similar to his adjacent tissues. So coming to the rehabilitation of the mandibular defects, as I mentioned earlier, the mandibular defects can be rehabilitated either only with soft tissue free flap or osteocutaneous flaps. So when a patient is rehabilitated with soft tissue free flap, there is always a deviation of the remaining jaw to the contralateral or the defect side, which causes muscular imbalance, and the patient is not able to use the existing dentition to masticate. What we do, we make a physical therapy appliance that is guided by prosthesis, which has an extension. As you can see in the lower picture, there is a small extension in that. And what we do, we try to engage the prosthesis so that the jaw doesn't move forward. So it helps to train the muscles, the masticatory muscles, to remain in this position and makes the jaw very free. So whenever we ask the patient to use the process at least 8 to 10 times, 8 to 10 hours a day, which helps in training the muscles. And also, once the process is in place, the tongue is properly centered. If the tongue is properly centered, and it helps in masticating the food. As you can see in the left uppermost picture, the chin is in normal position after placing the guide wide processes. In this, the jaw is deviated. You can see the deviation of the chin.
We can also fix the orthodontic buttons and give patient elastic band, rubber bands. So there is a constant pull continuously. So patient doesn't have to only wait for 8 and 10 hours. It is continuous pull. So it helps patient much better, and there is no cumbersome appliance in the patient's mouth. This works pretty well if provided teeth are strong and there is good bone support.
What about the angulation of the jaw? Because the jaw also gets
That
tilted.
is not that the tipping moment you can't achieve even with this processes. That eventual this which is the tipping is there, the contact is already shifted this way. That's the saddest part. Unless until you do tubular reconstruction, but that is the reason we say condyle, preserve condyle on that side.
So coming to mandibular defect, which was reconstructed with the fibula. This was a patient post RT, he has come to us post RT, 3 years post RT. You can see we have planned 4 implants which are placed in the fibula. This is after the healing and the attachment of the abutments. The prosthetic part was performed after 6 months post placement of the implants to assure proper osseointegration of the implants in the fibula. You can see the impression was recorded, and this is the processes in series. Coming to the rehabilitation of the auricular defect with implants. So this is a case of an acquired auricular defect. Patient has met with an accident, and she lost her complete scalp, and after undergoing multiple plastic surgery, this is how she came to us post 1 year of the accident. So you can see the left ear, you can see just rudimentary structures are remaining, and so we had planned for providing her with implant supported auricular prosthesis. For that, we have done some initial marking from the external auditory meatus taken as the center, and we have planned the planning start with forming a radiographic stent. So with the help of the markings, we make a radiographic stent, and placing the stent in place, a patient is sent for scanning with the radiographic markers. So once the scan has come, and this is how you can see the stent is in place. Initial drills are made using the stents.
One is cranial and one is caudal implant. So we place one in cranial and temporal and
Master.
yes, master. So over there, air sinuses are there. So we do push in that. We have maybe implant length of 7 feet to 4 millimeters. we get special maxillofacial implants. And, so that stage is placed in the special face, and then we take CT scan, so we know how much exactly.
So two implants were placed and we are waiting for the implant to heal so that after 3 months we can plan for this processes for that. So coming to a partial vasectomy case, this is a female which came to us for replacement of her dentition. She was a case of a partial CA tongue which was operated in 2016. Partial vasectomy was performed and followed by radiotherapy. So it was almost now 8 to 9 years post RT, and the patient was a good and ideal candidate, young patient, post RT 9 years, ideal scenario to consider her for implant supported rehabilitation. Since the mouth opening was an issue, and also we can see in the lower picture where the partial prostatectomy, this lower arch, we can see managing the flap would have been a challenging in the lower arch. So we considered flapless guided surgical procedure for her. Okay, flapless surgical. This is a video actually which will be showing how we plan for the placement of the implant using a latest surgical guided techniques. And in the lowermost picture, you can see this is a guide which is being made, and we place this guide. And to our implant placements. So this is how the lower 4 implants were placed and the upper implants. The surgery was divided into 2 stages: first one arch and next time second arch. And this is how the 4 implants in upper and 4 in lower were placed. And we are waiting for the implants to osseointegrate and provide her final dentition. So coming to this last, this is taken from a journal. So basically here the jaw reconstruction of the patient diagnosed with the amyloblastoma, treated with the maxillectomy and reconstruction with the fibra free flap. So what was done? The tumor was first delineated on the magnetic resonance imaging using radiotherapeutic planning software. 3-dimensional virtual surgical planning for the tumor ablation surgery was done, and virtual surgical planning of the maxilla and orbital floor reconstruction with the fibula, bone and implant planning was done. As you can see, suprastructure was fixed and 2 endosseous implants were placed in the fibula bone segment. This is a picture which shows fibula placement and 2 implants placed, and processes was given. So to conclude, this was just an overview of a prosthetic rehabilitation which is possible in head and neck cancer patients. Involvement of a multidisciplinary team to prepare and execute the rehabilitation treatment is of utmost importance. Maxillofacial prosthodontists should be involved from the beginning, and their role in the process is essential and guiding. The rise of 3D techniques in diagnostic planning and rehabilitation is enormous and is expected to evolve to the standard of care. So this is why I'm showing this slide. This was the first patient of our dental department, and the story behind this case I wanted to tell you was she was coming all the way from Orissa just to remove her teeth because she went to 2-3 dentists and nobody was ready to remove the teeth. The teeth was causing trauma, and a granulation tissue was formed around that. So we had helped her with that. And this is our dental team here in HNCI headed by Dr. Dilip Deshpande. Thank you.
What I would say that if we are involved in surgical planning, then possible to give you better quality of service for our patients. We can make pre-surgical prosthesis. We can also identify areas even if patient cannot afford. We can, if we can preserve safety procedure on the contralateral side, that itself can give support, medical support that the prosthesis cannot work. So if such things will be done, then that will be much better. Right?
Especially like you mentioned that you might want to preserve fungi. I think the disease process
Yes.
allows
It makes a lot of difference. Which cases? So heavy mandibular communication. Heavy mandibular communication. Even if you are not, even if you are not placing the fibular graft,
if you don't place a fibula, then how does it help?
most of the time then you are putting the plate. If not,
So the question is, if I don't put a fibula for primer
uh,
and I put a soft tissue deconstruct, will that condyle
no,
help you?
no, it will not. If there is a reconstruction there, then will be.
And what about when I remove the pterygoid, the temporalis, the masseter, just preserving the end joint and the fungi will
Because
Then supporting.
So it is the coronoid with the temporalis and the fungi. So you're going to resect above the lingula and preserve that horizontal segment.
Also, we have seen the type of osteotomic cuts that are made and how they are approximated. So if there is a point contact, then the chances of osseointegrating between the two osteotomy fibula is little difficult, and using those fibula for the placement of the implant and giving processes is again a questionable. So approximating the surfaces of the fibula osteotomic cuts is important for.
Similarly, in anterior region, when you take sections, say central incisor is there, then you have to remove the other central incisor. Instead of going through the septum, go through the width of that, so that the septum, the same lateral wall of that socket is preserved. That tooth has got much more longer span of.
I had one doubt. In fibulas, I have seen plastic surgeons doing two techniques. So in Tata, they used to do multiple osteotomies and give different segments, like the lateral segment, body, and central segment. But there are few plastic surgeons who just put a middle strut of the bone, and rest they use a reconstructive plate. So will that make a difference in putting your implants?
I think that's so fibula is just in the anterior segment,
Yes,
not in
and
the lateral
no,
aspect of it.
and when that the plate,
Just plate is extended
yeah,
up
up
to
till
the upper condylus
right,
section.
right. So in the lateral part there's a plate and middle part there's a
So
bone.
where there is a fibula and if it is nicely osteointegrated, as you're saying, it's an anterior region, you can always give an implant and give just an anterior teeth. We cannot give anything behind because whatever we give, it will be again an unsupported.
So giving that lateral segment is
Is
better than
rather than just, and we are performing surgery, we are doing so, getting complete is always advisable.
In a cantilever fibula, if there is no contact, you will not be able to give a denture.
So we will be able to give a denture.
We can give, we do give. Then same way we have to train the patient to go for the training plans or give on the contralateral those elastics. Patients do learn to bite on that side and know that condyle comes on the feet, but not condyle the mandible keeps on moving whenever there is a chewing effort. The chewing efficiency is almost reduced to 20% or so, but they can chew. Okay. They can chew because of the muscular. Little play. We have done quite a few cases that way.
how often have you been able to give implants into the fibular graft?
Sorry, sir.
How often are we giving implants into the fibular graft?
As a rule, we should do in all cases. As a rule, sir, we should do in all cases.
Primary, secondary.
Yes, and if we can,
Primary or secondary?
so if we can tie up with an implant company, we can reduce the cost and we can that will make patient's life easy.
Primary or secondary?
Primary or secondary? At the time of surgery
At
or
the time of surgery. At the time of surgery, only anyone of us can join you, place implants even if patient goes for radiation, still we can give some prosthesis which will give him quality of life. Whether patient survival rate we are not talking about, but at least we can give quality of life for those patients.
When there is no circus, circus, the implants and the denture doesn't hurt the cochlear mucosa.
So in that case, sometimes what we do, we intervene, we do a sulcus vestibuloplasty procedure, and with the help of many implants or temporary implants, we provide a plate so that for the until the healing period. So once the sulcus is formed, then the final procedure is given to the patients.
Is all that possible in
So try few cases.
So what is described right now is the possibility of putting an implant prior to doing your fibula reconstruction. So they will expose the fibula and implant it on the leg. So we give it additional of 15 days prior to your surgery. So osseointegration takes 4 to 6 weeks. So our surgery and post-op radiation is anyway 4 to 6 weeks. So if you do it at the time of surgery, you're still getting between 4 to 6 weeks before the radiation starts. The implant is embedded and it is not exposed. So the patient will never get any hurt, will not be hurt by that implant being exposed. It's only after the radiation is over that at end of 6 months, then the implants are exposed and an abutment is given.
Most of the time we fix the gingival attachment on those implants so that we do not have to even take a cut to expose the implant.
So that was first concern that during radiation.
So your patient only that Mr. Choradi, we already placed implant prior radiation, and he is coming for restoration. And we placed 4 implants, 4 are integrated. We had already fixed the gingival healing screws. Now is coming this week for restoration. Once the restoration is done, I'll send him to you so you can have a look. It's functional.
What is the average cost of this implant to counsel the patient?
For now, like we have done one case, so a 4 implant will be costing only the surgical part if we consider. So it will be costing around say 90,000 only the surgical aspect, including implant, the procedure cost, the consumables involved. And so depending upon how is the case, we will decide whether to give a removable denture or a fixed denture. So again, the cost will be very in that.
So what's the range? What's the maximum range?
It may go around
For
the overall placing implants, the cost of implant as well as the prosthetics. So
this the one which we showed this case, that is one of the cheapest way on 4 implant we can get full arch prosthesis. It comes in the markets around 3 lakhs rupees or so. Over here we are cutting down to 90,000.
90,000 per batch.
That is with the prosthetics.
Without processes. With processes, you might go to
Probably more than another 10,000.
So that's what we are able to perform in a bulk. So we can still further cut down on the cost, and we can tie up with some lab also for the prosthetic part, or we have in-house technician, we can train them and get the work.
At Tata Hospital, to answer Sir's question, 1% of patients underwent implants.
Sorry?
1%. So the ones who had a fibula reconstructed, 1% went. But the ones who actually got the prosthesis and all were the ones where they were placed intraoperatively. Because then the patient is more motivated, just like a T prosthesis. He's motivated to have the prosthesis if it is embedded during surgery. After surgery, after radiation, just in such a miserable condition, then they don't want another procedure. And also the implant failure rates are higher in a radiated bone. So almost 30% of implants are failing in literature. So it is better to do it if you plan it out, the patient is fit, the disease burden is less, your survival rates are higher, and patient wants a rehab, it should be done primarily.
The new design of implants for mid-trabecular implant can be loaded within 10 to 15 weeks of installation. The design is different. It's got a bone structure in between the threads. I place quite a few implants. We load them immediately, and within 15 days you can. Suppose say you can. There is a time period between your surgery and radiation. In that way, we can give a permanent prosthesis on those implants. She doesn't have to even come back to us after it.
So we really have to select out our patients because not all patients are suitable. And the ones
Those
that
who
have
can, those who can,
good mouth openings, wherein you can actually do some procedure post surgery, those are the ones that might benefit. And of course, the maxillary defects, if you do a zygomatic implant, they do very well.
Maxilla is important to connect the horizontal section with the vertical section of a fibula or a plate. So again, there should not be cantilever again. So we have to consider this one.
No, Bajaj Singh is doing it only for benign cases. Or cases like amyloblastoma and all, not in squamous cancers. I would like what Ramesh mentioned for select cases where there's not too much of soft tissue invasion, which is confined to the bone itself.
No neck nodes. No neck nodes.
And no neck nodes. It's good prognosis cases. We should try.
Well, we can identify such cases and mark them for.
Yes.
We can work out with these implant companies for this case also they have reduced the cost.
We have actually tied up with us some CSR activity through a bank, and we have given 100 process. They've given 100 processes. So something similar can be done in order to facilitate, because most patients are inundated with the cost of the treatment itself. So the rehabilitation takes a backseat. If they can be supported for the rehabilitation, more patients are forthcoming. Otherwise, they are not willing. Costs are the major issues. And then again, most of our patients from out of town, so their travel back and forth is a big issue.
But still they come up every review after every 6 months or so.
So if you can actually have a network built amongst the maxillofacial surgeon or prosthodontist, so that the patient, when he goes back, has the support. That has to be good.
That is the saddest part. Nobody wants to test the patient.
So many patients now in the OPD, they have come just to get the rehabilitation, some sort of rehabilitation, dentures, bridges, everything are ready to do it here because outside in that area,
Nobody is doing
nobody is doing that.
Very last legs, even if last legs, patient comes from Gwalior.
Yeah.
Because nobody wants to repair it. Something broken. A simple thing which any local technician can do. They are scared to touch the patient.
And guided processes sometimes just so happen that buyer breaks. So they have the design in hand, but they don't know how to fabricate. So just for that, they come here, get it fabricated. Even occlusal guards, we are providing to the patient. So if it is an outpatient, what we do in our department, we give the models so that they have to just make it over there. Because
Right.
taking impressions in such cases is very challenging. So we already have a model with us. We ask them to preserve with you. For that thing, just to get one occlusal guard, they don't have to travel here. You can show to local dentists, ask us to coordinate with us, we can tell them what has to be done.
Well, prosthodontists are not trained to take impressions. That is the saddest part. Anyway,
Not
our
motivated.
Mumbai is the only place where we can make the impressions. Even in metro, this fats, we can do extraction of the third molar. Nobody else.
We extract the last molar almost
How
in
many
the
cases of yours you are saying this with this much of opening? I have removed them. We have developed the technique. It's without forceps. I extract without forceps. What to do? It's not possible even to put a forceps there.
At the time of surgery, we normally extract the last molars. Is it okay?
More important, sir, without hesitation. It's very difficult to extract those things.
It doesn't have contralateral peak.
Hmm.
And below there is a flap because of glycophomy. There is a flap. So it is better because over that flap, after radiation, we know that we won't be able to give anything in that area. So it is better to
So we do that. I just wanted your certificate on that.
In upper and lower both, we should remove only one.
Both.
Opposing.
These, as it is, third molars don't contribute to the mastication. Our maximum efficiency is up to the first molar. One second molar contribute 10% of mastication. So if they go, it doesn't matter. Because as they go closer to the condyle, there is more of the cause interference with the laterals. And especially after surgical procedure, second molars also come in way. Better to remove them. Even if your patient will preserve up to first molar, 90% is good enough.
And then
Is there any special instruments you can recommend for the shut mouth to remove the teeth? Which we can buy that.
I've given that set. I'll give it to you.
No, I don't have to
He
do
has
it.
extracted maximum teeth. He has taken. I'll get those set for you.
No, you don't have to give the set, you just send
I'll
this thing, PDF,
same whatever I have.
the root elevator, basically.
Something
these are
that's
sharp,
yeah.
what we call
The Metsi instrument.
excavator. We just go deep down and separate out the root from the bone. There is a perversion. These are called just
You know, sometimes the root breaks, you know, so then it's a big struggle.
Root removal kit, which again, it's very short and you can remove them.
But the life of these instruments is very
No,
short.
no, hopefully they give you a lifelong guarantee. They don't.
They don't get blunt. They don't get blunt.
No.
Our Indian ones, you know, you keep on using them. After some time, they're dead. Then you have to use
You
so much
remember,
force.
I've given, I have given the hospital who is this thing. It's a lifetime instruments. They don't get, now I'm using it plus 10 years. No.
No, I think you should send it to us now.
I already given.
Maybe we are not using it.
He has given quotation till down. He keeps on coming to me. उसका क्या हो गया? Now go again.
It's very important, otherwise we cannot explain.
This is a terrific struggle.
Yeah, the quotation he has already given. They're a bit expensive, but they're really good instruments. Angles are very small. You can reach anywhere and you can move this.
Otherwise, we have to curse and remove, so that's not good.
There is a dentist in Singapore. He's a nice bungalow. His driveway is all lined by teeth that he has extracted. He just puts it on the driveway. And then we'll come very close to that. Only when his teeth fly off.
Nair, I used to do that way during vacation time. Nobody used to be there. 30 chairs. I used to go giving injections, all come back to the while in the anesthesia that one extracting. I used to do some 200, 300 extraction in one session. I'm talking about now, when I was registered.
How much of the other oral pathology work you're able to do? These inflammatory lesions of the oral cavity, sometimes we are really forced with those cases. So my dental and major organ. But I don't think that
Raju Desai, oral pathology.
You're talking about dentigerous and cysts and
the dentist
keratosis.
surgical problems are okay, but the medical problems, bad inflammatory lesions.
Can be sent here for, they can have a review first. Ritesh and Rekha can have a review. And then we will also have a hygienist, so we can take care of it.
Generally, what we have seen, there's a tendency of getting white lesion in that areas. But whenever we see such lesions, there is always adjacent to there are a lot of stains, calculus, plaque. So initially, basic oral hygiene maintenance and giving some conservative medical line of treatment, we can observe them for say 1 month to 3 weeks, like 4 to 6 weeks, we can observe them. Things. And it is observed that such lesions that it has to be kept in under close observation. They will never heal completely.
So we have, prior to our surgery also, if we have some time, in a week's time, if we send to them during surgery, our dental hygiene is so much better. So the flap uptake, the reduction in the flap breakdown is of significance. And post-op, before the patient starts radiation, the entire dental care has to be done. I think at these two time points, if the patient is brought in contact with the prosthodontic department, it will be very useful.
Initially, there were 2 3 cases which were sent for pre-surgically.
Yeah.
So after the surgery, actually initially the teeth were much mobile and everything, and but after surgery the teeth which was great but mobile since we have performed scaling and prophylactic measurements
Yeah.
initially. They were quite firm post surgery and the oral cavity was looking quite good.
So we tend to then remove the tooth because it looks bad. But if you all have taken care of it before surgery, then we may not really go ahead and
We
extract.
can always note down and send it forward to you. So these are the things which needs to be extracted. So patient doesn't have to undergo after surgery again extractions in the dental department. So that we can always.
All sharp teeth and all those things. Before the surgery, if we attend them, it's much better. And most important, motivating these patients for hygiene. 90% of them, they don't keep because of intraoral opening. They develop secondary caries. It's very difficult to even address those. Most of the time, as we said, we have to scoop out with the hand because we can't drill the soft decay, and then we put the glass kind cement, which is one of the better options. We can't do anything else. It's that setting cements.
And also the fluoride gel application. I think that is very
But
critical.
even if we have done fluoride, hygiene still has to be maintained. That is the problem.
So all our post-radiated patients should come to the department every 3 months or 6
Actually,
months.
these people should be using water picks. I give water pick to all my patients. Because it's very difficult to obtain them also. They are available. They are not so expensive. They cost me around 3,000, 3,500. We give it to the patient as a gift. So they think gift from the dentist means something important. And if the gift is they keep it. Most of them they use it, but then because that is where the brush doesn't go, the tip goes in maintains.
Yes, we have.
We have it.
Yes, sir, we have it.
Very good. I buy it in bulk, it comes to me around 2,500 to 3,000 rupees per bottle.
is important for us.
Very important.
But it's becoming we took and we never really utilized.
And we need it in our procedure rooms. So that the patients can be, even if a post-op, like you were talking about the power spray, this is an adequate spray.
We didn't install the power spray because I said we will use water.
Yes.
I think your department is very, very valuable to our goal of delivering quality healthcare.
And it's dentistry has got a great future because nobody is brushing teeth. Most of the patients, there's either just too bad. Majority of them with the tobacco.
No, but even those that are good,